and how we go about choosing these antibiotics and their treatment strategies. Over to you, Dr. Grabowski.
Dear chairs, dear colleagues, here are my financial disclosures. None of them is relevant to the topic of this presentation. So we do have some historical knowledge about the common microorganism in post-operative endophthalmitis. You see the table in the upper part of this slide taken from the ECRS guidelines, for example, showing the prevalence in percents. Then we know also, this is another table, that it might differ according to the different types of the endophthalmitis, let's say, the causes of endophthalmitis, or as you see, post-cataract or intravitreal injection, glaucoma, filtration surgery, keratoplasty, trauma, and of course, endogenesis. Another factor that is important, that we know that the etiology is different in various regions. For example, in countries such as India and China, the percentage of gram-negative and fungal cases can be much higher than in Europe and the US. And that there is a higher rate of streptococcal infections reported in Europe, for example, compared with US. And to make the thing even more complicated, we know that because of the increasing role of the resistance, this pattern of resistance is different in different countries. This is the map showing the resistance to methicillin, to Staphylococcus aureus, epidermidis in different parts of Europe. So finally, to best adjust the intravitreal antibiotic, we need to have the local susceptibility testing and the knowledge about the local patterns. I would like to present you, this is the just recently published our book, 2 weeks ago, I think. I will cover many of the information in this presentation based on this book. I'm pretty sure that you might find it helpful for detailed information. It's a very practical textbook. So what are the intravitreal antimicrobials for presumed bacterial cases? Of course, vancomycin, and for coverage of gram-positive organism, ceftazidime for coverage of gram-negative organism, for presumed fungal cases, amphotericin, and or voriconazole. Amikacin may be substituted for ceftazidime. However, we need to be aware about the risk of aminoglycoside toxicity that are similar to gentamicin. Then ceftriaxone may be substituted for ceftazidime if more readily available. I will not discuss the role of steroids. And here we can see, this is again the table taken from our book, so not in detail, just to mention that there are some alternative antibiotics that can be used, or antimicrobials here for gram-positive organisms like linezolid and quinopristine, daptomycin, tigecycline, and for gram-negative organisms, imipenem, ciprofloxacin, levofloxacin, moxifloxacin, and for fungal organisms, miconazole, caspofungin, and micafungin. We should be also aware about some possible complications associated with the intravitreal injections. They include, of course, mechanical complications, like a damage to the crystalline lens, phakic eyes, peripheral retinal tears or retinal detachment, wound leak, elevated intraocular pressure, and finally, toxicity of antimicrobials. And they include, for example, for aminoglycoside, risk of macular infarction, what we can see in the right upper part of this slide. after intravitreal amikacin, for example. And this is pretty well known, the risk of vancomycin as a hemorrhagic occlusive retinal vasculitis, and it is shown in the lower left part of the slide. So the choice of intravitreal antibiotic is mostly empirical, as initial treatment typically occurs without access to any laboratory or cultural results, and should cover the most likely causative agents. So it is usually vancomycin plus ceftazidime, as I mentioned. Vancomycin effective against the most gram-positive cocci, ceftazidime effective against most gram-negative bacilli. And then it is further modified based on the susceptibility spectrum once such results are available. And for cases when we suspect some multi-drug resistant bacteria, including gram-negative bacilli, we can use imipenem, piperacillin, tazobactam, and colistin. Regarding frequency and safety, it depends on assessing the clinical response to treatment, microbiological results, toxicity of the chosen drugs, and retreatment when the treated eye is not stable, does not improve after the first 36, 48 hours, or there are signs of worsening. At the end, I would like just to show one study recently published proposing a triple therapy adding to vancomycin and ceftazidime moxifloxacin. As you can see here, that according to the authors offers some advantages, expanded coverage of gram-negative organisms and potential synergy. So thank you very much for your kind attention.
Well, thank you so much for this excellent overview on this very important topic in endophthalmitis. As mentioned before, we will discuss at the end of the session with the panel. And now it's a pleasure to announce the next speaker, Sibel Demirel from Turkey on fungal endophthalmitis.